and heads at Raj's Dental College, Tamil Nadu, and occasions, contributed chapters to reputed textbooks and serves on the editorial boards of several journals. Now, before we proceed, a quick reminder on the presentation. We begin our session, and I invite our first presenter to showcase their work. Registration GS1260.
Good afternoon, everyone. Good afternoon, chairpersons. My topic for today's presentation is precise prognosis, a crucial complement to accurate diagnosis. First, what is prognosis? Prognosis is the prediction of the outcome of the disease, the duration of the disease, depending upon the treatment we offer to the patient. So this must come after the diagnosis but prior to the treatment plan. Now, what is diagnosis? Diagnosis is the complete analysis of the case history, the clinical examinations, the signs and symptoms which we elicit from the patient, from various tests we do. Then we come to a final decision. This is the diagnosis. For this, we can generally evaluate the patient, or we can take his or her prevailing oral conditions also. Traditionally, we take these methods to obtain the diagnosis. Like as mentioned earlier, you can take a thorough case history, clinical examinations, radiographic methods, lab techniques like hemograms, biopsy techniques, etc. But obtaining a mere diagnosis must not be our final step. Our aim must be to provide proper treatment plan to the patient. For this, the crucial step must be attaining precise prognosis, so that in the long run or for the long-term management of the patient's lesion or condition. As oral pathologists, we come across a lot of oral cancer cases. So here I would like to elicit few of such examples. This is case 1 of a 27-year-old male patient. He presented clinically with a small white patch on his left lateral border of the tongue. He didn't have any habits at all. Incisional biopsy turned out to be mild epithelial dysplasia with no invasion. Treatment provided was complete local excision of the lesion, review, recall every 3 months. Now this is case 2 of a 60-year-old patient with 15 years of pan chewing habit. He presented clinically itself as a vertico-proliferative lesion in his buccal vestibule. Incisional biopsy turned out to be moderately differentiated carcinoma. Apart from that, histopathologically, there was no signs of invasion into the adjacent blood vessels, muscles, or adipose tissue. Moderate inflammatory infiltrate was found surrounding the tumor cells. So this patient was referred to the oncology department. For further investigation, CT was advised to know the TNM staging, and turned out to be there is no distant metastasis or lymph node involvement. Treatment provided was wide local excision of the lesion, complete removal of the regional lymph nodes, and a proper chemotherapy regime was advised. So, in the case 1, what all factors affected in the prognosis of this patient? This is the 27-year-old patient with no habit history. Here, the factors which affected was his younger age. He was only 27 years old with no habit history, and there was no microscopic invasion also. So definitely the prognosis of this patient will be better than that of the second case. who is a 60-year-old male patient with 15 years of plant-chewing habit. So a knowledge of these factors complemented in the final diagnosis and helped to execute a proper treatment plan for this case 1. While in case 2, he presented the 60-year-old man, that patient presented clinically itself as a suspicious lesion of carcinoma, which necessitated further investigation of CT to know the TNM staging, and it turned out to be moderately differentiated carcinoma. So in this case, what all prognostic factors were taken into account? That is his older age, habit history. Already he was a debilitating patient with 15 years of plant-chewing habit. He presented clinically itself as a suspicious lesion, his histopathological diagnosis and TNM staging. How these factors are affecting his prognosis is described in this slide. Since he is a tobacco user, if he is planning to continue his tobacco usage, of course the prognosis is going to be poor. If he is planning to cessate, of course it will be better. Tumor differentiation and grading. There is well, moderate and poor. If it is a well differentiated tumor, then he will be having a better prognosis. TNM staging to know the extent of the primary tumor. Earlier the stages better the prognosis than the advanced. If at all there is any distant metastasis or tumor or non-involvement, then his prognosis is going to be poor. Traditionally, we consider these factors for prognosis. Apart from that, there can be challenges in finding the prognosis. For example, like there can be uncertainty in the etiology, uncertainty in the histopathology, inadequate follow-up from the patient's side. There can be genetic and molecular variations. There can be variation in the vasculature of the tumor microenvironment. There can be complexity in certain diseases. There can be complexity in the molecular pathophysiology also. So, what all future aspects must we consider? See, in that case, one of 27-year-old male patient whose diagnosis was leukoplakia with mild epithelial dysplasia. As an oral pathologist, what I feel as mild epithelial dysplasia will be moderate epithelial dysplasia for another oral pathologist. So here dysplasia is a subjective term. So creating trustworthy markers for its classification is essential. Second, reliable circulating biomarkers to know the circulating tumor cells in the body. We can use serological, histological and genetic methods. Then imaging and artificial intelligence assisted diagnostics must be implemented. Nowadays, omics sciences are of utmost popularity, so proteomics, transcriptomics and metabolomics must be considered to avoid the obstacles in finding the prognostics. As a conclusion, I would say that diagnostic difficulties do arise due to the variations in the clinical, radiographic and histopathological characteristics. Prognosis depends upon the extent of the disease and the biological potential of the lesion. Even after we reach a conclusive diagnosis, a precise knowledge about the prognosis can help in comprehensive planning and give a proper or effective treatment to the patient. Of course, areas of uncertainty will be there which must be explored and worked upon. These are few of my references. Thank you for listening, attending my presentation. Thank you.
You have just mentioned leukoplakia. Once we diagnose, so leukoplakia is a clinical term, I think. Then it will be moderate, simplex or complex we mention, or sometimes mild, moderate, severe dysplasia we generally consider. And what prognostic value, even in younger case, if this is leukoplakic patch is there, it may be verrucous one. Because leukoplakia is more aggressive one, I think.
But yes sir. Verrucous, if it is going to that side, of course. Here, what I intended to show is the we must give importance to the prognosis and diagnosis must go side by side, hand in hand. That is the aim why I took
Case
this.
one having any habit?
No, case one is not having any habit, but he is a young patient who came with a patch clinically. He presented with a small white patch in his lateral part of the tongue. That's why in incisional biopsy, when we took it, turned out to be mild epithelial dysplasia.
Prognostic value.
Yes, sir. Like for example, I am saying, sir, in that case one doctor, I'm eliciting it with example of these two examples. Suppose that in the 27-year-old patient, he went to a doctor and he diagnosed it as mild epithelial dysplasia after taking the incisional biopsy. In the second case, when that 60-year-old male patient went to another doctor, he presented clinically itself as a suspicious lesion, which made that doctor to consider more prognostic factors, like he considered his age, his habit history of 15 years of habit history. Then he took incisional biopsy. Apart from that, he took CT scan to know the TNM staging. Even though there is no lymph node involvement, he did the TNM staging and apart from the histopathological diagnosis, and he removed all the regional lymph nodes, so that in the long term of a long term management of the second patient, both these doctors' diagnoses were correct only, but in the case of first patient, if the patient, we are keeping it at risk. The doctor advised patient review and recall every 3 months. But that is like you are keeping the patient at risk. Rather than keeping the patient at risk, the second doctor, he considered more prognostic factors and took appropriate treatment so that it must be effective for the patient also. That is the
Good, doctor, that you've done a good presentation. I appreciate your part on giving an emphasis on prognosis. But as sir mentioned, you have to also consider the parameter of proliferative verrucous leukoplakia. So he had specifically mentioned that. Then in addition to that, any other parameter that you would look at? You said it's risk, the first lesion, we're speaking about the leukoplakic patch that you're treating. Does the site play a role? Is there a significance of the site in the prognosis?
yes, sir. Usually lateral border of the tongue is highly
Lateral
potential.
border and floor of the
Floor
mouth.
of the mouth.
Why so? Why do you think? Any guesses on what do textbooks normally tell you?
Maybe little trailing lymph nodes.
Okay, more than that, it's the permeability of the
Yes, sir.
mucosa. And another most important parameter that you have to consider is the pooling of your carcinogens. Okay, you have the saliva pooling at the floor of the mouth and the base of your tongue.
Yes.
So those sites are where you have a lot of carcinogens which tend to accumulate. So that gives an indication that it's probably at a higher risk.
Yes.
So those parameters are what you have to look out. So when you're telling the patient, you have to make sure you emphasize on these points. The location, whether it's a proliferative verrucous, whether there's a lack of habit, and if you have multiple leukoplakic patch, then it gives you a better understanding to the patient that they're at a higher risk. So these points you have to slightly emphasize. Otherwise, it's a good presentation. Good.
Thank you, sir.
I now request participant number DS1267 to please proceed to the podium.
Good afternoon, respected judges. Today I will be presenting on proliferative verrucous leukopenia through this narrative review, and which says that aggressive rodal lesion at the crossroads of uncertainty and the malignancy. So now here are the contents which I will be discussing about. So according to World Health Organization, what is leukoplekia? Leukoplekia is described as a white patch or plaque which is found on the mucous membrane that cannot be removed by scraping and cannot be clinically or pathologically identified as any other condition. So now we will discuss about the various clinical forms of leukoplekia. So first one is the homogeneous leukoplekia, followed by non-homogeneous leukoplekia, proliferative verrucous leukoplekia, sublingual keratosis, and the oral hairy leukoplekia. So now through this narrative review, we will only delve into proliferative verrucous leukoplekia. So according to Hansen et al. In 1985, proliferative verrucous leukoplekia stands out one of the most aggressive and unpredictable forms of oral leukoplekia, and it is a progressive multifocal exophytic white oral lesion which found on the high malignant potential, and it is rare, chronic and multifocal oral mucosal disease with relentless patterns of recurrence, and significantly there is a high transformation rate of malignancy. While establishing PVL, lesions are typically raised and bulky, and they often begin as a flat patch which before progress into the exophytic form. So, in 1985, the term proliferative verrucous leukoplekia was introduced in Hansen et al. In 1997, a follow-up study was done by Silverman and Gorski. In 2005, WHO recognized PVL as a rare subtype of the true oral leukoplekia. In 2010, Cedric Lepidra proposed a set of major and minor criteria, which I will be discussing about in the subsequent slides. And in 2018, Villa et al. Suggested a defined set of criteria for classifying a lesion as a PVL. So the prevalence is very rare, and it is less than 1% than of leukoplekia. And the sexual predilection in sexual predilection, we can say that the female are more prone to this disease. And the age group is 40 to 60 years, and the most common sites are gingiva, followed by buccal mucosa, tongue, alveolar ridge. And the lifetime malignant transformation rate is 60 to 100%. So what is the etiopathogenesis? So basically till now we don't know about the exact etiopathogenesis, and we can always say that there is possible roles of viral, immunological alterations and genetic susceptibility, and this is different from any other OPMD because this is mainly tobacco independent. So we will now discuss about the molecular basis. At first, the accumulation of the early genetic epigenetic alterations can be there, and followed by the cellular changes and the DNA damage can occur, and nextly followed by the p53 gene mutation, and there will be accumulation of the secondary mutation, and p53 gene gain oncogenic functions and actively promotes, which helps in the invasion and the metastasis part. So now we will discuss about the clinical features. So proliferative verrucous leukoplekia, it appears as white patch or plaque, and which does not rub off, and it is a relentless and progressive course, and which involves forms an initial and often flat lesion, and which is exactly like thickened, rough and warty and exophytic kind of appearance in this picture, like we can see in this picture. So it is multifocal and multicentric, and the location, as we earlier discussed, that it mainly affects the gingiva, followed by the alveolar ridge and the buccal mucosa, and followed by the tongue. So now the symptoms, it is basically asymptomatic at the first, and the demographics are more commonly seen in the elder women. The malignant potential rate is the highest among all OPMDs, and the recurrence is very high. So now we will discuss about the Cedric-Lepidra criteria in 2010. So he proposed some major criteria and minor criteria. So major criteria is leukoplekic lesions with more than 2 different oral sites. Existence of verrucous site is there, and the lesions have spread and engrossed during the course of this disease, and histopathological diagnosis should be there. And the minor criteria includes the leukoplekic lesions occupies at least 3 cm, and the patient should be female, and the patient is a non-smoker and discussed, and disease evolution higher than the 5 years. So malignant transformation rate. So while transforming in Campisi et al. In 2004, he did a study and 25 of cases of PVL, and he explained that 14 patients were transformed into the SCC. Began et al. In 2011, he did a study on 55 patients of PVL, and he spoke that 11 cases have transformed into the SCC. Gondafu et al. In 2009, 19 cases he did on the patients of 19 patients, and 11 turned into SCC. And Fabian et al. In 2020, he published a series of 48 PVL patients, and the malignant transformation is 15 among those. So now we will discuss about the histopathological features. So these include hyperkeratosis, epithelial hyperplasia, acanthosis, epithelial dysplasia, and the chronic inflammatory cell infiltration. And in epithelial dysplasia, it is 6 to 6% to 36% rate, and which runs into the malignancy. So the differential diagnosis, so when we discuss about the differential diagnosis, we have to distinguish between normal OPNDs and with PVL. So in simple leukopenia, the distinguishing features is strong association with the tobacco or alcohol use habits, and the solitary it is solitary and stable over the time, and then lower risk. And in verrucous carcinoma, it is represents a well established and bulky tumor mass, and it is already malignant. And in the oral lichen planus, the distinguishing features is the Wickham stripe, and the burning pain sensation is there, and it has a very low risk of malignant potential. And the chronic hypertrophic candidiasis, it is a response to antifungal therapy. It responds to the antifungal therapy and removable risk of potential malignancy, and it regresses completely after the antifungal treatment is done. So the surgical management part, in the management part, so we will discuss about the surgical management. So this includes wide excision, laser ablation, the cryotherapy, the high recurrence rate despite the adequate margins, and the recurrence requires immediate interventions. And the non-surgical therapy, retinoids, photodynamic therapy, CO2 laser, and immunomodulators, role of antifungal and antifungal therapy can be there. And in the follow-up, the lifelong meticulous follow-up after every 3 to 6 months is mandatory, and early detection of the malignant transformation improves the prognostic value. And recently, we can discuss about the oral metronomic chemotherapy, and the metronome means it produces audible sound at the regular intervals. Through this OMC protocol, we can be said that high dose of celecoxib of 200 mg twice daily, and which is a COX-2 inhibitor, and low dose of chemotherapy 15 mg of methotrexate can be used once a week. And the challenges are undefined etiology and inconsistent diagnostic criteria, which has a high recurrence regardless of this treatment. And the future direction, it includes standardized diagnostic and staging protocols, which includes the identification of the early molecular biomarkers, like collaborative multicentric studies for improved understanding. And in conclusion, we can say that proliferative verrucous leukopenia remains a perplexing and formidable oral lesion, which bridges in the gap between the benign uncertainty and the malignant inevitability. And recent molecular insights and biomarkers discoveries are reshaping are without the understanding and offering hope for earlier detection and the target intervention. And it is a related progression and high malignant potential constitute to challenge the clinicians. So here are my references, and thank you.
Can you tell me if prophylactically leukopenia does it cure the retinoid, and you have just said immunomodulator?
Sir,
Can you name immunomodulator? Sorry, it is not related to pathology. I am just asking.
I can't recall, sir.
Okay.
Yes, sir.
I never seen this retinoid, and in clinically they can even might be, but I never encountered them reducing the size or curing this leukopenia.
Sir, after biopsy is the gold standard, sir.
And biopsy for diagnosis, and only treatment, I think it is surgical removal.
Surgical removal is the best, sir. Sir, but if any patient, sir, doesn't go with the intervention and he continuously ignores the lesion for a longer period of time, so we can use it as sometimes this kind of placebo treatment, sir, and often it is can be used for the definitive diagnosis.
It's a good presentation. You've given an overall overview of proliferative verrucous leukopenia. I think you mentioned, let me just go back to your slides where you mentioned about hyperplastic candidiasis, and you mentioned about it having a malignant transformation potential. One of the references we are.
Yes.
So why do you think it tends to have this potential? Why does candidiasis have a potential? What are the concepts that have been proposed? It's in your slide, that's why I'm asking you.
Yes.
Okay?
Yes, sir.
My professor used to always tell me,
Yes, sir.
whatever is in the slide, you should be able to answer.
Yes, sir.
Otherwise, don't put it in your slide.
Yes, sir. Yes, sir.
So now you put it, I'm
Yes.
asking you that.
Yes,
So,
sir. In candidiasis, sir, when some PVL is already detected, sir, so after biopsy, or we can say before that it can lead to PVL part. So candidiasis is kind of adjunct, sir. So it can happen.
what is that component that they normally say can activate to go for a dysplastic change? What are the concepts that are related to it?
Concepts
Look up about nitrosamines and their relation with how candidiasis can probably have a role with dysplasia. Just go back and just have a look.
Okay.
There's one more slide about OMC that you have put. That's a new concept that has come towards the treatment.
Treatments, okay.
Treatment, no. Next slide.
So this,
Low sound.
Low sound I am also.
so this was
No, next slide probably.
After that.
OMC you had put, right?
yes, sir. OMC.
Yes, yeah.
Yes.
So, what is your insight on this? What is the literature that's supporting it? Do you have any?
Sir,
Because this reference is pretty old, 2011, so almost like 15 years now.
sir,
But based on your analysis of literature, do you have any article which supports that there is a reduction in the incidence of this
yes,
particular
sir. Yes, sir.
PBL?
Yes, sir. So, this article, sir, by Vinay Hajare, sir, we have attended that webinar, sir, so that's why
Okay.
But
Uske baad, did you go back and try to get more journals and look at
I have read that this particular journal.
only
Sir.
journal?
Yes,
Okay.
sir.
After
Yes,
that, you've not looked at other journals.
no, sir. Other journal, sir.
You have to update yourself. Okay, so whenever you send your articles for publication,
Yes, sir. Yes, sir.
not more than 5 years
Okay, sir.
is what they normally expect. You're getting it for a very good index chart.
Yes, sir.
Anything abroad you go, this is what they look at, your presentations and everything. Okay, you can quote this.
Yes, sir.
But in addition to that, you should have a recent data also to substantiate.
Okay,
It's
sir.
a good presentation, no fault with all that.
Okay, sir.
But just keep this point in mind that whenever you're putting up, if you put this reference, put another one that's within a recent time. Minimum of 3 years. 5 years is when you're going for a publication.
Sure, sure.
Okay?
Yes.
Good.
Thank you, sir. Thank you.
May I call upon the third participant, TS1156.
Good afternoon, chairpersons, delegates. Today I will be presenting on the algorithm-based diagnostic pathway for radiopaque jaw lesions, imaging insights, and histopathological validations. My presentation will be focusing on an algorithm which provides a simplistic approach to the diagnosis of radiopaque lesions of the jaw, which are usually seen in OPGs and RVGs, which are beneficial for the patient as well as for the clinician. So, with the introduction of this algorithm, jaw lesion encompass a wide spectrum of pathologies. Radiopaque lesion present a significant diagnostic challenges due to overlapping clinical and imaging features. Important to distinguish is whether the radiopacity is attributed to a normal network structure or it is an artifact or indeed pathology. Final diagnosis requires a multi-pronged approach integrating clinical, radiological and histopathological findings. The differential diagnosis of radiopaque jaw lesion involves various factors such as attenuation pattern, marginal characteristics and their relation to the teeth. Radiopacity can be classified as densely sclerotic, ground glass or mixed lighted sclerotic, each indicating distinct, sometimes overlapping diagnosis. A systemic approach is essential to avoid misdiagnosis and delayed treatment. So the objective of this algorithm is to present a practical algorithm to evaluate radiopaque jaw lesions using imaging features, correlate imaging findings with likely histopathological diagnosis, provide clinical decision points to guide biopsy and its management. So the most common radiopaque jaw lesions are odontoma, cementoblastoma, osteoma, idiopathic osteosclerosis, condensing osteitis, fibro-osseous lesions with calcification, sclerosis osteomyelitis, osteosarcoma and other malignancies which are rare. So the proposed steps and diagnostic algorithms with an overview is, the first step is we'll confirm whether the radiopacity is true or it is an artifact. If it is an artifact, then we'll repeat the radiograph or adjust the exposure. In step B, we localize whether the radiopacity is periopical, which is tooth related, or bone related, or medullary. In step C, we'll assess the borders, like whether they are well defined or ill defined permeative. In step B, we check its relation to the tooth, whether it is attached to the root, resorption is there, or fusion, or it is separate. In step E, we'll check the effects on adjacent structure like cortical expansion, perforation, and tooth displacement. In the next step, we'll check the density and internal structures, like if it is homogeneous dense, mixed radiolucent, or radiopaque. Radiopaque masses resemble tooth structure. In the last step, we check the clinical signs like pain, swelling, infection, and systemic symptoms. So the radiopacity seen in OPG are mixed lytic, dense sclerotic, and ground glass. In the mixed lytic sclerotic, it is due to bone destruction and new bone formation. In the densely sclerotic, it is due to unerupted teeth, abnormal hard tissue production, thickening, and increased density of bone. And the ground glass is due to disorganized calcification caused by either a neoplastic process or abnormal bone remodeling. So the mixed lytic sclerotic, we see the first their aggressive features. If the aggressive features are present, then we'll take the clinical history. If the clinical history gives us the chronic infectious features, then it is most probably chronic osteomyelitis. And if there is history of radiation or angiogenic agents, then it is the symptom of osteoradionecrosis. And if the history of malignancy or non-contributory history is there, then it is osteosarcoma of the jaw or metastatic invasion. If the aggressive features are not seen, then we will see the location of it, whether it is tooth associated or non-tooth associated. If it is tooth associated, then it can be developing odontoma, COF, or CEOT. If it is non-tooth associated, then it is we'll come back to the ground glass algorithm, which we will discuss further. So these are the features of histopathological features of chronic osteomyelitis, which is seen as sequestrum surrounded by involucrum and fibrous granulation tissue. In osteoradionecrosis, we see fibrosis, chronic inflammation, and thickening of vessels. In osteosarcoma of the jaw, we see presence of malignant osteoblast or tumor bone. And in developing odontoma, CEOT and COF, we see sheets of polyhedral epithelial cell, myeloid, and leaf gangrene. In densely sclerotic, we see whether it is periopical, pericornal, or non-tooth associated. If it is tooth associated, then we will see whether it is pericornal or peripical. If it is peripical, we will see the margins, whether they are ill-defined or well-defined. If the margins are ill-defined, then it is condensing osteitis. If the margins are well-defined, we will see the root attachment. If there is root attachment, then it is mentoblastoma, and if there is no root attachment, then it is mentoosseous dysplasia or frontoma. In the non-tooth associated, we will see the cortical expansion, whether it is expanding to the bone or not. If it is expanding to the bone, we check for the symptoms of bilateral symmetric distribution. If the bilateric systemic distribution is there, then it is the sign of torus or exostosis. And if there is no bilateral distribution, it gives a sign of osteoma. And in the pericornal, if the density sclerotic is pericornal, then it is a sign of odontoma. And if the cortical expansion gives a radiolucent halo, then it is mentoosseous dysplasia. And if the radiolucent halo is not present, then it is idiopathic osteosclerosis. So this is, I think, the older PPT which I have submitted. So that's why there is some animation mistakes in this. So with the ground glass appearance, we check for the extraoral features. If the extraoral features are present, then we will see the radiographic constellation. If there is radiographic constellation, then we will see the signs of paged axial lesions, cotton wool spots, or tam-o center sign in older adults, which is a sign of polysclerotic paged disease of bone. And if we see salt and pepper skull, rugged jersey spine, or characteristic lytic pattern associated with CJD, then it is renal osteodystrophy. And if ill-defined fusiform bone expansion or intact minor dura is seen, then it is polysclerotic fibrous dysplasia. And if the ground glass appearance doesn't show any extraoral features, then we see the margins, whether they are diffuse, ill-defined, or well-defined. If the margins are diffuse, then it is a sign of cherubism or monostotic Paget's disease. And if the margins are ill-defined, it is a sign of monostotic fibrous dysplasia. If the margins are well-defined, then it is mento-ossifying fibroma. Now the histopathological correlation. If in the odontoma, we will see histopathologically enameled dentine pulp-like tissue arranged in tooth-like structures, which can be compound or complex in a disorganized mass. In cementoblastoma, we'll see sheets of cementum-like tissue with active reversal line fusion to root. In osteoma, we'll see mature laminar bone with Hessian system. In idiopathic osteosclerosis, we'll see dense laminar bone without inflammatory cells. In ossifying fibroma, we'll see fibrous trauma in with variable bone, bony and cementum-like calcifications. And in osteosarcoma, we'll see malignant osteoid, aTPM mitotic figures. So the conclusion and takeaways of the presentation is an algorithm imaging approach improved diagnostic confidence for radiographic jaw lesion. Histopathologically remains the gold standard. Use decision notes like symptom growth, tooth relation and borders are helpful in guiding the biopsy versus the observator. Thank you. And these are the references. The references are not there because this is an old PPT.
Means radiographically we can diagnose how it is related to which disease.
Thank you for your question, sir. Actually, when the clinician is trying to take a biopsy, till that time when the biopsy report is there or to give a differential diagnosis, for that purpose only, we can use the radiographic images and the radiolucency like its margins or the clinical symptoms like pain, swelling, or whether the cortical expansion is there, or some features like rug spine, like clinical features of the patient to give a differential diagnosis before the biopsy reports come and the treatment can be started immediately. So these are not true observations, like we can just give a differential diagnosis for the
algorithm. You have used the term algorithm means?
Sir, algorithm means like how to check a radio opaque lesion, whether it is coming in which graph, like if it is ground glass, it is mixed lytic, it's sclerotic, density sclerotic, and then furthermore, like which area it is expanding to, which other symptoms we are getting. So we can have a particular symptom for particular disease, for particular lesion. So we can give a differential diagnosis for that.
Good, you've actually done this, but I just want to know out of curiosity, this algorithm was defined by someone that you followed?
Yes, sir. It was I have taken it from an article and modified it according to my thing. Yes, it is an algorithm. It is a study article performed in Maulana Azad, Delhi. So I have taken it. It's not older article, a recent one. Like 2 years
Good
back.
that you've actually done it, but what are the changes that you've done? Can you just highlight the ones that you've basically modified?
Yes, sir. Actually, that algorithm which was presented in the article was very complicated. Complicated in the sense like the whole graph algorithm was shown on the single page with the complexity like ground glass, like I have turned the ground glass, we will check the ground glass appearance if mixed lighting is there and we will not find anything. Like I'll show you in this slide.
So what are the changes? It would have been good probably flowchart where all you made the changes for the existing algorithm and why you possibly made that if you had highlighted in your conclusion. Then this would actually stand out and you could have actually sent it out for a publication also. So there is a existing algorithm and you proposed a new one.
No, I have not proposed a new one. I just modified it
okay.
for the
So
ease of understanding.
whatever you've done a modification. Say,
Yes, sir.
so you modified it and this is the modification that you've done, you can propose that. Okay. So but now when you're just presenting it, we really don't know how it is different from the previous one. Okay, so whenever you're getting some work, if you've done something new, you have to highlight. That's the crux of what you're doing.
Yes, sir.
Okay.
Like in this, if it is not true tested and we are seeing
So probably it is the new presentation you would have added, I'm not sure. But you should make sure that you emphasize on that. Okay. So these are the changes that I've done and this is how it is. So once you do that, it's always better. Okay. You stand out from the rest of them. Okay. Otherwise it's look like you've just taken some material and put it. But you've done some modification. Highlight that. Okay. So now it's okay. You've done it, it's fine. It's good. You've done a good presentation.
Thank you, sir.
Participant number DS1148.
Good afternoon, judges and dear delegates. I am presenting my systematic review on diagnostic accuracy of fine needle aspirations cytology in comparison to conventional biopsy in cerebral gland neoplasm. Starting with the introduction, the fine needle aspiration cytology or FNSC for cerebral gland pathology, it is minimally invasive diagnostic procedure for frontline diagnostic tool for screening and preliminary diagnosis, whereas conventional biopsy is remain gold standard diagnostic procedure which allow assessment of both cellular morphology and tissue architectures which help in tissue grading and the scoring. It which is not possible in case of FNSC. These tables summarize the core difference between the FNSC and the conventional biopsy, where FNSC are rapid, less invasive, and the rare and the minor complications, whereas conventional biopsy is more invasive but having very high diagnostic accuracy. So our core review question is simple yet vital, that how accurate is FNSC in comparison to conventional biopsy for diagnostic of cerebral gland neoplasm. For this, protocol was registered under the Prospero ID, and following the PRISMA guideline, we search for major databases like PubMed, Scopus, Web of Science, and the Embasis. To search the study, identify a study from 2005 to the 2024 using these keywords, where the two independent reviewers done screening, data extraction, and risk of bias, with third reviewers resolving any disagreement if happened. The inclusion criteria was providing comparative diagnostic data on FNSC and biopsy for cerebral gland neoplasm and the published data in English language, whereas exclusion criteria were non-neoplastic lesions, study without comparative data, and the study done before the 2005. And the result was this Prisma flow diagram of my systematic review, so that we starting with 16,662 cases studies. After the removal of duplications, we left 14,459 study for screening. Then the title and abstract screening were done. Then we left 133 full text articles, out of which 77 studies were removed due to the absence of histopathological correlation of FNSC and the lack of acceptable data in some studies. And then finally we left 56 studies for qualitative and quantitative analysis. And then qualitative analysis done with using JBI critical appraisal checklist, which give the strength and significant methodological limitation across the study. This graph shows that breakdown of the responses for key methodological questions, where the best scores having the highest green bars, whereas low scores having worst scores having the red and yellow bars. Then these tables show demographic details of my included 56 study, where the country-wise we saw that around 20% of data is from the India, followed by Iran and the Italy, where the studies are 7%. Again, the mean age is very variable. The lower age is 14 years, whereas the highest is 63 years. And also the highest studies having the middle age group population is affected. The gender-wise distribution show more numbers of male patients than the female patient. Then this table summarizes the sample size distribution between the benign, malignant, and the FNSC follow with histopathological correlation, and the diagnostic outcomes like true positive, true negative, false positive, and false negative values. For this, looking for the pool data, we found that total true positive cases is 25% around, and the total true negative cases is 65%, and total false positive and false negative cases are 4% and 6% respectively. Then this table summarizes the presence of comparison of diagnostic performance parameters like sensitivity, specificity, positive predicted value, negative predicted value, and the diagnostic accuracy of FNSC in comparison to conventional biopsy. Then the pool data show that the sensitivity is very variable, where the lowest value is 38% sensitivity, whereas the highest value remain 100% in all the cases, whereas specificity is 82% lowest value, and the diagnostic accuracy is 76%. Then we further analysis look into the FNAC performance based on the tumor site, where we saw that the diagnostic accuracy of malignant lesion is higher than the benign, whereas sensitivity and specificity is comparable or slight decrease in case of malignant lesions. Same was done in the tumor site, where we found that the parotid gland has high diagnostic accuracy and the sensitivity and specificity. So to discuss, from the global data set, we found that almost 20% of study from India, which highlights high incident and the widespread use of FNAC in diagnostic cytopathology, whereas the male to female ratio is 1.3:1, which suggesting moderate male predominant in the study. Then the sensitivity is very variable. This variability is mainly due to sampling method and the expertise for cytological process in diagnosis of cell gland pathology, whereas specificity is more than 90% in 39 out of 56 studies, which give ability of FNAC to confidently identify the malignancy, whereas the diagnostic accuracy is more than 85% in 35 out of 56 studies, which confirm that FNAC as a highly reliable preoperative diagnostic tool. Then positive predicted value is more than 80% in 30 out of 56 studies, and same was the negative predicted value, which is more than 90% in 20 out of 56 studies, which support that FNAC is safe in ruling out the neoplastic lesion in benign and malignant lesions. Whereas false positive rate is less than 5%, which signify higher reliability of the FNAC, whereas the false negative rate is higher, quite mainly due to the sampling error in FNAC procedure. Then FNAC performance based on tumor types, there is overall diagnostic accuracy high in malignant lesion, as we seen there, because it is easily recognizable, and however sensitivity and specificity is slight decrease or comparable due to morphological overlapping, sampling error and the interpretational challenge intrinsic to the cytology. Then the FNAC performance based on the tumor site, where we saw that the higher diagnostic accuracy in parotid gland, mainly due to better accessibility, large gland size and easier lesion localization, which enable adequate sampling and the higher cellularity during the cytological procedure. The major limitation in my studies mainly heterogeneity in the study design and the reporting, inconsistent subgroup analysis like tumor site and specific data is insufficient, unavailability of the complete statistical data in some publications. Despite these limitations, pooled findings were robust and the consistent across the multiple regions and the institutions. Then to conclude, FNAC demonstrate high diagnostic accuracy, excellent specificity and the low complication rate, making it reliable, minimally invasive preoperative diagnostic tool for salivary gland neoplasm, and also that guide clinical decision making effectively. These are my references. Thank you.
Said that false positivity due to sampling error.
Yes.
So which kind of sampling error, which was false positivity?
Sir, like sampling error during the insertion of fine needle goes not adequate site, sir. Like in expertise of person which done this.
We have to based on it is we are reach up to proper site or not.
Yes, sir. Or that we can
Diagnosis
take.
is depend upon the skill.
Yes, sir. Or proper depth we are taking or not. Yes, sir.
Okay, it's a good systematic review that you've done. You've done a lot of analysis of data.
Yes, sir.
So much for looking at the volume of data that you've done through. And you've used basically 2 investigators also, so that makes your study more authentic. Good that you've done it, but you're saying that you have certain amount of false positivity and
Yes.
negativity also, right? So, what do you think? FNAC can be used as a gold standard diagnostic tool, or it just is an additive? What is your take on it?
Sir, from my point of view, sir, it is adjuvants to the biopsy. Biopsy remains the gold standard, but sir, it can prevent burden of patient for biopsy and also prevent the complications which is higher in biopsy. So
Good. So, you're saying that's just an adjunct
Yes, sir.
in addition to when you need a biopsy. Okay, good presentation.
thank you, sir.
Participant number DS1292. Good afternoon, judges. Good afternoon, everyone. My topic is role of artificial intelligence in diagnostic oral pathology, a modern approach. Introduction. Over the decades, new equipment was emerged in medical field and we have witnessed the importance of medical imaging such as computed tomography, magnetic resonance imaging, ultrasound, mammography and X-ray and their contribution in successful diagnosis and treatment of various diseases. Machine learning has played a significant role over the years in nearly every aspect of the STEM in medicine. It is a system that takes in data, finds patterns, trains itself using the data and gives an output. Machine learning like statistics is used to analyze and interpret data. Recently, deep learning, a subfield of machine learning, has risen to a forefront of AI community. Deep learning technique is described as the application of multi-layer artificial neural network to a wide range of problems, and they are very effective at analyzing imaging. Convolutional neural network, one of the most popular deep learning tools for pattern recognition tasks, very effective at analyzing the images. Despite the perceived threat of AI, it is possible that AI tools can be boon to a pathologist by increasing their value, efficacy, accuracy, and personal satisfaction. Different image learning categories and algorithms are used in this. Oral cancer and machine learning. Oral and pharyngeal cancer grouped together is the sixth most common cancer in the world. Given the rising incidence of oral cancer, there is an immense need for tailored approaches to prevention, screening and treatment intervention. Need of a method that effectively use pre-treatment disease information to categorize similar patients suffering from oral cancer and improve their overall treatment rate, thereby enhancing overall quality care. Tseng et al. In their study adopted an integrated procedure that combines the clustering and classification features of data mining technology to determine the differences between symptoms shown in past cases where patients died from or have a survivor oral cancer. Application of artificial intelligence in pathology. Microscopic morphology is considered as a gold standard in diagnostic pathology. Pathology specimen undergo multiple processes that include formalin fixation, grossing, paraffin embedding, tissue section, and finally staining. In general, it is human pathologists that provide pathology diagnosis by observing stained specimen on the glass slide using a microscope. The main limitation associated with morphology diagnosis is the variability among the pathologists. Therefore, consistent and more accurate diagnosis, it is important to introduce AI in the pathology domain. Lately, numerous attempts were made in which the entire histopathological slide was scanned and then saved as a digital image. Artificial intelligence in the diagnosis of oral disease. In the USA, approximately 1 million biopsies were performed in the cancer of prostate. Among them, only 20% are found to be positive for cancer. This implies that pathologists are spending huge amount of time looking at the benign tissue, which is general, can be easily distinguishable from cancer. This point out the need for computer-aided diagnosis that allows the pathologist to focus more on difficult to diagnose cases rather than sailing through benign tissues. For pathologists, cancer diagnosis is time-consuming, subjective, and inconsistent due to the inter- and intra-observer variations. This further necessitates for the need of computer-aided image classification system with quantitative analysis of histological features for rapid, consistent, and quantitative cancer diagnosis. Landini and Othman introduced a novel method for labeling layers in histological section of multi-layer or polystratified tissue. However, this approach was entirely two-dimensional, may be useful as a formal descriptor of the spatial arrangement. In another study, Landini and Othman measured statistical properties of a graph network to characterize geometrically the architectural organization of normal, pre-malignant and malignant tissue in 2D section.
Their result indicated unbiased and reproducible quantification with discriminatory rate of 67%, 100% and 80% for normal pre-malignant and malignant cells respectively. In 2015, Das et al. Developed a computer-assigned quantitative microscopic method, i.e. an automated segmentation method for the identification of keratinization and keratin pearl from in situ oral histological images. This method achieved 95.08% segmentation accuracy in comparison with expert-based ground truth. Das et al. Proposed a two-stage approach for computing oral histology image where 12-layered deep convolution neural network is used for the segmentation of constituent layers. In the first stage and in the second stage, the keratin pulse are detected from the segmented keratin region using texture-based features trained at random forest. Detection accuracy was found to be 96.88% for the detection of keratin pulse using texture-based random forest classifier. Liu et al. In 2016 developed a computer-aided method for the diagnosis of tongue cancer in an animal model in which cancer was chemically induced. The following histological process of tongue tissue representative areas of the stained tissue were captured for classified tumor and non-tumor tissue. Texture feature describing epithelium structure was the most discriminating feature. They obtained an average sensitivity of 96.5% and a specificity of 99% for tongue cancer detection. Jairaj and Samuel Nagar in 2019 developed a deep learning algorithm for automated computer-aided oral cancer detective system by investigating patient hyperspectral images. They have obtained a classification accuracy of 91.4% with sensitivity 0.94 and a specificity of 9.91 for 100 image database. Artificial intelligence as a oral cancer prognostic model. Machine learning is not new to cancer research. According to the PubMed statistics, majority of the paper published on machine learning and cancer were concerned with using of such learning method to identify, classify, detect or distinguish tumor and other malignancy. It is always remained a challenge for the researchers to predict the cancer treatment, outcome or prognosis. Over the past 2 decades, the body of the literature in relation machine learning and cancer prognosis has increased in majority of these studies. Gene expression profile, clinical variable and histological parameters are encompassed and fed as an input to the prognostic procedure. In cancer prognosis or prediction, one is concerned with 3 predictive tasks: prediction of cancer susceptibility, prediction of cancer recurrence, likelihood of redeveloping a type of cancer after complete or partial remission. It is evident from the literature that when both clinical, pathological and genomic data were used, the prognostic results of cancer are more accurate. Change et al. In their study applied a hybrid feature selection and machine learning method in oral cancer prognosis. Their results revealed that the prognosis is superior with the presence of both clinical, pathological and genomic markers. Exarchos et al. Aimed to identify the factors that dictates oral squamous cell carcinoma progression and subsequently predict potential relapse of the disease. They suggested a multi-parametric decision support system and exploit heterogeneous sources of data such as clinical imaging and genomic. This study listed in an explanatory way how the integration and heterogeneous sources of data. By means, the machine learning classifiers can produce accurate results regarding the prediction of cancer recurrence. Mobile mouth screening anywhere. Researchers from Princeton University and University of Malaya working on a project that is mobile mouth screening anywhere app, which is used to capture image of the oral cavity for remote interpretation by specialists. They will train a deep learning system that distinguish between thousands of photos with and without sign of oral cancer, then integrate that system into the app. Conclusion: even though it is encouraging that the pathologic finding in AI is expanding to disease severity assessment and prognosis prediction, still a large amount of data is needed to develop AI that covers the range of clinical situations. Image analysis method for digital pathology are rapidly finding application in cancer diagnosis. One has to remember that it is pathologist who can provide the feedback on the system's performance, and his knowledge, advice and supervision become more important. Pathologist should be afraid of losing his or her position due to this advancement in pathology. On the contrary, pathologists will be the best equipped to interpret the finding with the help of AI, and deep learning in turn will lead to the new research ideas. These are my references. Thank you.
Your topic is on, it's a good topic, AI in diagnosis of oral pathology. You are talking about only carcinoma, not other disease.
Yes, sir.
You are cover only one part.
Yes.
What about the rest part?
Uh,
AI in implemented in dentistry. So it can be used in caries detection, it can be used in premalignant lesion, it can be used in radiological findings. What are the limitations of AI?
Sir, firstly we need a total database to compare the results or prognosis, and AI is not exclusively or अकेले खुद वो नहीं कर सकता, डेंटिस्ट ही प्रोवाइड कर सकता है जो मेन उसका कंसाइज है रिजल्ट है उसको.
Okay, a very elaborate presentation, but as I mentioned, you should have included all parts, right? So you just stuck to one core concept here.
Yes, sir.
And what you should have actually done is just put out the key points. I'm not saying that your presentation was not that. You've sort of got everything into your slide.
Yes, sir.
Only the key point, there's this, I presume you know it, 6-line, 6-word rule. Do you know that? In any scientific forum when you're presenting, you should have maximum of 6 bullets. Okay? And the maximum number of words in each bullet should be a maximum of 6. Okay? In any forum, international or national. Okay? So probably in your next presentation you can improvise on that and then get it out. Since you've put too much, I'm just telling you that. But otherwise it's well thorough search and you've done a good job of going through too much of literature. And you could have just added a little more, and for a presentation pattern you can just slightly improvise. Okay, good.
The last presentation for the day, DS1436.
Good afternoon, respected judges and everyone. Today my topic is on dental DNA, a unique source in forensic odontology. In this presentation, we explore how dental tissue is an important and reliable source in forensic odontology. So let's begin with short introduction. Dr. Oscar Amido is considered as father of forensic odontology. The term forensic means court of law, odontology means study of teeth. Kaiser in 1970 defined it as branch of odontology which deals with the proper handling of examination of dental evidence and the proper evaluation and presentation of dental finding in the interest of justice. Now, role of forensic odontology, useful in disasters such as earthquakes, tsunamis, fires, and exposure, severely mutilated, charred, or decomposed bodies where there are scanty remains left and morphological tests like fingerprints may not be available. Sex determination can also be done by dental DNA. Age can be determined by estimating the telomere shortening of the chromosome from a tooth DNA. Now, brief history. A forensic dentist is 4500 years old. One of the first dental identification was logged in 2500 BC Then two molars were linked together by gold wire were found by Janker in a tomb located at Giza. A new era of forensic dentistry started in 17th century when a body was recognized from its dental details. A practical application came into action in 19th century when a criminal was convicted on the basis of dental evidence. The famous personalities identified by the dental DNA, German dictator Adolf Hitler, Pakistani President General Zia-ul-Haq, and Indian Prime Minister Mr. Rajiv Gandhi. Why tooth is a unique source? Because of tooth are hardest structure in the body, the tooth has capability to survive any extreme environment with minimum risk of contamination, making it a unique alternative source of DNA. It can survive decomposition and autolysis as well as environmental insult like water immersion, burial, and fire as hot as 1100 degrees Celsius. Teeth have well preserved DNA even after many years and act as an alternative DNA source. Now, source of DNA. Source of DNA is dental pulp, dentine, cementum, and periodontal ligament. Now, types of DNA. There are two types of DNA, that is genomic DNA and mitochondrial DNA. Genomic DNA present within the nucleus of cells and mitochondrial DNA present within mitochondria. In the year 1953, that Watson and Crick discovered the DNA structure to be double helical in form. This is the double helical structure of DNA. Now DNA sterilization. Before DNA extraction, the tooth is cleaned with sodium hypochlorite 0.5% and washed with the distilled water. Let it dry without tempering the temperature and then put through the ultraviolet light for 1 hour. In case of intact tooth recently extracted from the alveolus, a regular endodontic access opening is done along with the instrumentation. Pulp chamber is curated and pulp collected in a sterile tube. Then tooth crushing may also be required. The pulp chamber should be irrigated with a buffer. Now tooth is ready to retrieve the DNA sample. Sampling techniques of DNA from dental pulp. These are some techniques: crushing entire tooth, vertical split of entire tooth, conventional endodontic access, cryogenic grinding, horizontal sectioning, orthogrind, and trace technique. These are the techniques most commonly used: cryogenic grinding. Coating the whole tooth to extremely low temperature using liquid nitrogen and grinding it to fine powder. Major drawback is tooth is to be completely crushed. Less destructive method is drilling the root canal and stripping the pulp area. Now DNA purification. Dental DNA extracted from any source, then tissue extraction should be done. Cell lysis takes place there, that is physical or chemical. Then wash step by detergent, separation of DNA by specific adsorption membrane, then removal of membrane lipids and protein denaturation, then removal of other cellular contaminants, then RNA removal by RNase. Then add the slightly alkaline buffer, double distilled water, then purified DNA is ready. Now factors affecting the DNA content in tooth. Factors affecting the tooth type, largest the pulp volume, and preferably started with the molars are the first choice of DNA extraction. Then chronological age. Advanced age leads to decrease in DNA content, so factors like extent of tooth wear, adhesion, and abundance of cementum should be considered while selecting the sample. Dental disease, caries or microbial disease lead to dissolution as well as destruction of the calcified structure in teeth. Now DNA profiling, DNA fingerprinting. DNA profiling is the process of determining an individual DNA characteristics. DNA profiling is also known as DNA fingerprinting, DNA testing, or DNA typing. Types of DNA fingerprinting techniques, that is hybridization based technique, RFLP, restricted fragment length polymorphism, PCR based assay, that is polymerase chain reaction, sequence based technology, that is dissection of the SNPs, single nucleotide polymorphism, reverse dot assay. Now, limitation of to DNA fingerprint. DNA lysis takes place after death due to the enzymes such as DNase. So it is difficult task to obtain DNA from remains. There are high chances of contamination during collection, storage as well as transportation. Now, a summary. The tooth can survive in extreme environment with least possible risk of contamination, making it a special due to the unique placement of tooth in the jaw and their structure. DNA present get extra protection compared to bones, so frequently become the only source of DNA that would be available in adverse situation for identification. Now conclusion. Various DNA profiling methods are there with their advantages and disadvantages. Obtaining a DNA sample is an adequate quantity and quality remains a challenge due to various factors as discussed. Observing all the factors, it is clear that tooth is an excellent source of DNA. Current research is dedicated on developing methods that yield good DNA from degraded and compromised samples. These are my references. Thank you, sir.
Nice presentation, but you have just extracted DNA, and
Yes.
how you compare with previous one? When a person died in any accident, suppose Rajiv Gandhi,
Yes.
and how you find
Compare with family members by the taking sample like buccal swab, saliva,
swab of whom?
or no, not bone, sir.
I have a DNA. When I compare with previous one, then I can say that
Previous one, sir. Okay,
Previous
I
one
don't
from
think.
previous one from where you get?
Uh, previous.
How you compare?
So we take DNA from then compare with family members
Only
for
family member.
identification.
Any other source?
It's a good presentation. Actually, you've gone through everything. Okay, so you've done about using the tooth as a specimen for your extraction. But what you should remember is there are two methods. I think you've just mentioned about sectioning the tooth or pulverizing the entire tooth. You can also use a demineralization method where you decalcify it and then use the demineralized fluid to analyze your for the DNA. Okay, but irrespective of what it is, one disadvantage, as you rightly pointed out,
Yes.
DNA tends to become denatured.
Yes.
So any degraded material,
Yes.
my question to you is, which is the minimum amount of DNA that you would require for further amplification or analysis? How much in picograms? Less than this yardstick, you can't use it. Don't know?
7 nanogram.
Okay, so it's normally 200 picogram. When you have anything less than 200 picogram, you can't use that specimen for analysis. It becomes very difficult for an amplification and then to get more content of your required gene of interest. Okay, so less than 200, we really can't use it. It's a good presentation. You've done a good work of compiling everything. Good.
Thank you. Okay, okay, sir. From here, sir, hair follicles. Okay, sir. Hair follicle after death, sir. Okay. Thank you, sir.
With this, we conclude the paper presentation. We would like to extend our heartfelt appreciation to all the participants. Each presentation was truly commendable, well prepared and thoughtfully delivered. Every participant has showcased excellent effort and academic sincerity. While the judges are finalizing the results, we request everyone to kindly be seated for a minute. The evaluation process is still going on and the results will be announced shortly. Thank you.